Hi, I'm Doug Ringwald. Today I'm going to talk about shoulder alignment in downward facing dog. First, I'm going to go over the anatomy terms of movement for the shoulder, so we're on the same page with the terminology. Then I'll talk about shoulder alignment and then cueing that you can use with your students with downward facing dog. Then also I'll go over the common causes of shoulder pain and movement limitation. It's not injury. It's trigger points in the scapular stabilizers. And then I'll show you how to assess scapulohumeral rhythm. And then I'll go over two good counter poses for down dog that address the scapular stabilizers. And then lastly, I will show you how to make those counter poses even more effective by applying post-isometric relaxation or contract relax stretching. Okay, so first of all, let's go over the shoulder movements. So here are a couple videos. This first one is going to be showing the abduction and the adduction of the arm. So that's arm abduction, the arm's moving out away from the center line of the body in the coronal plane, the frontal plane, and then adduction is when it comes back towards the center of the body in that plane. All right, so one more time I'll show that one. So arm abduction away from the body, adduction coming in towards the center line of the body. And next we have the arm flexion. So that's arm or shoulder flexion. And this is arm extension. And that's full extension right there. So when talking about the shoulder or the arm, they're both basically referring, shoulder or arm are referring to the glenohumeral joint. So that is where the humerus, the arm bone, so the upper arm is known as the arm, and then past the elbow, this is the forearm. Okay, so the arm, basically the humerus, and then the glenohumeral joint then is where the humerus comes into the glenoid fossa, which is the shoulder, and that is the scapula. So you can refer to this joint as the shoulder or the arm or the glenohumeral joint. And then we basically have, we can define the movements of the shoulder, then we can break those down into the glenohumeral movements or the arm movements, and then the scapular movements. So these first, so the arm abduction, adduction, those are arm movements, the glenohumeral joint. And then flexion, extension, that's another arm movement, glenohumeral joint movement. And now another, now I'm going to show the arm rotation. So here's external or lateral rotation of the humerus in that glenoid fossa, and then medial rotation. Okay, so external rotation and the medial rotation. So those are the different types of movements of the arm in those three different planes of movement. Now we'll move into the scapular terms. So here is protraction and retraction. From the back, there's protraction and retraction. So this is referring to the protraction, also known as abduction, is when the scapula comes forward around the rib cage. So it has to move out along the rib cage and forward at the same time. So it's moving in two different planes. So we call that protraction or abduction. And then, basically the scapula is moving away from the spine. And then when the scapula is moving towards the spine, then we call that retraction or adduction. protraction or abduction, and then retraction or adduction towards the spine. So those are scapular movements. So that's just defined by what's happening with the scapula. And then we have one more. Scapular elevation, scapular depression. So scapula moving up towards the ear, elevation, depression moving downward. Oops, almost forgot. There's one more scapular movement to talk about, and that is the upward and downward rotation. So as the arms abduct, the scapula have to upwardly rotate, and that looks like this. So the scapula upwardly rotate, and now on arm adduction, the scapula will downwardly rotate. So one more time. Whoops. Upward rotation. Downward rotation. Now this is, if you mark where the inferior angle of the scapula is, it's easier to see. So if I marked this point right here, this is the inferior angle where here's the medial border, and then the scapula turns the corner here and goes this way. So if we look at where this point is right here, we'll see that the scapula upwardly rotates, so the whole thing moves upwards. And then for downward rotation, the scapula, that same inferior angle, rotates back down. So now that we have these terms defined, let's talk about shoulder alignment in downward facing dog. First, I'll show you a couple of examples of what I would not recommend. So here is a woman, very flexible, and you can see that she's doing her downward facing dog, and her elbows are actually going into hyper extension. So you see that bend here in the elbows. And then you can also see that her shoulder is not in line with her torso. It's more like 190 degrees or so, maybe even more. So the normal range of motion of the shoulder joint in terms of flexion should be 160 to 180 degrees. That would be full range of motion, and she's well past that. So what happens when you go past that, when you go past 180 degrees, is that you're basically putting a lot of stress on that glenohumeral joint, and you're putting a lot of stress on the deep connective tissue in the joint capsule, and in the ligaments. So that's not something that I would recommend. The way that I approach yoga is, I want, in most asanas, in most poses, I'm concerned with building balanced strength around the joint, in the muscles around the joint, and stability in the joint. And pushing into hyper extension in a joint is promoting instability in that joint and might actually damage the joint capsule. So this is not something that I would recommend, this or what's happening here with the elbow. So a lot of people that are hypermobile are attracted to yoga because they can do all sorts of the pretzel poses, and they're quote good at yoga. But a lot of people are pushing into these extreme ranges, and they're not doing this stuff in a healthy way, in a way that promotes balanced strength in the muscles and healthy joints. Here's a picture of Iyengar doing a similar thing, except his back is more neutral, whereas the previous woman was in actually extension of the spine. So he's more neutral here, but his shoulders are really past 180 degrees of flexion. And so he's hyper flexing the shoulder and he's hyperextending the elbow. So I would not recommend doing that or teaching that in yoga poses for the reasons I just explained. Here's another picture of a woman with hyperextending elbows. The normal ligament ability to stretch is maybe like 3%. If you have, hypermobility in a joint, you might have double that. You might have like 6% stretch in the ligaments. And the ligaments are not there, they're not contractile tissue. They're there to provide stability. So they're not stuff that you really want to, that should be stretchy. And you shouldn't be encouraging them to become any more stretch. So I would avoid this. The other thing that she's doing too is her scapula are elevating, and there's very little space here because of that. The shoulders are riding up, and they're not kind of depressing and are more secured onto the rib cage. So here's me doing downward dog, and so there I'm checking out my hands, making sure they're even, kind of wiggling into the pose a bit, checking things out. So here you can see my back is neutral. My shoulders are a little bit less than 180 degrees, maybe more like 170. I'm not pushing. I have a lot of hypermobility. I'm not pushing into the furthest I can go in terms of my shoulders, because my purpose is to build strength. So I basically want my shoulders to be kind of depressing down towards my hips, and also the scapular stabilizers engaged to stabilize the scapula. So primarily the serratus anterior and the low and mid trapezius. And there's a few ways that you can do that. Also, my elbows here they're actually a little bit of flexion. So I tend to do this in yoga poses. I encourage this for people that have hypermobility issues, is to always keep a little bend in the joints, keep a little flex in the joints. Don't even go into full extension. Keep the muscles engaged around that joint. So my arms are almost straight, but not quite. Let's watch the rest of this, see what I do. Okay, I'm just kind of experimenting into the pose a little bit. So what I did there was I was just checking out my positioning, and my shoulders were kind of riding up a little bit higher. So I let my shoulders just relax down my back a little bit more. And then I engaged the scapular stabilizer. So one cue that you can give your students, or you can think about yourself when you're doing these poses, is that if you tell someone to press through their hands with equal pressure, and then to subtly take their inner elbows up towards the ceiling. Basically what you're cueing is them to externally rotate their humerus bones. And what that does then is that slight little movement, and there's no real movement, it's isometric contraction. So there's a contraction, but there's no overt movement. That external rotation of the humerus then gets your scapular stabilizers to engage and hug the scapula securely against the rib cage. Now here's me demonstrate what I don't recommend. So here I'm going into, a little bit past 180 degrees of arm flexion, shoulder flexion. And I'm getting more lordosis, more extension in my back. And so what I prefer is to reduce all that and have a very neutral back, and don't go past 180 degrees with the shoulder flexion. Different people also have different ideas about the drishti, about where the gaze should be. In Ashtanga, it's at the navel. A lot of other practitioners and teachers will say it's between the feet. I will try both ways. I'll do both ways depending. If I actually gaze at my navel, then that's going to put my neck into a lot of flexion. Sometimes I want to do that, sometimes I don't. But it does bring awareness here. And then another cue you can give people is to lift their navel towards their spine, and that will get them to engage their Uddiyana Bandha. And it also takes the extension out of the low back and gives them a little more flexion, which most people are in extension all the time in their low back, and their backs can't flex. So that's something that I've personally worked on over time to get more mobility in my lumbar spine in terms of being able to actually flex it instead of being locked in extension all the time. So here I'm going back out of that, and you can see how I'm in abducting. I'm keeping my shoulders wide, and so my scapula are moving away from the spine, and my serratus anterior is engaged to do that. But then they're also depressing, and they're kind of relaxing down the back. And now I'm going to show the same pose from a different view. So here I am settling into the pose. And now see what I just did there was I felt like my shoulders were too close, my arms were too close to my ears, and so what I did was I widened my shoulders. So I engaged my serratus anterior, and I basically, told myself, just widen your shoulders, engage your scapular stabilizers. So you want wide shoulders, and then let them relax down towards the hips. And then I got a nice, now I have nice space here. Now I have nice space here in between my neck and my arms, and my shoulders are much wider. So now I'm pushing into more shoulder flexion, and my back is not neutral anymore. Now it's going into more extension, and there's not a lot of, there's more extension. The shoulders are narrowed. There's more adduction. They're coming in closer to the spine, and they're going into a lot of flexion past 180 degrees. So this is how I would not recommend how to do this. And now I'm going to come out of it and readjust my position. Yeah. So there I kind of gave myself a cue to keep my shoulders wide and turn the inside of my elbows up towards the ceiling slightly. That isometric contraction that will cause the scapula to abduct, to protract, to move around the rib cage, and to engage and be secure against the rib cage. And now I let my shoulders depress a little bit more. So I'm really kind of experimenting with that. And there right at the end, I found a pretty good space. Some people recommend actually elevating the shoulders. So that's where the scapula move upwards, and this space gets very narrow. And I don't really understand that, because I just like, if I'm promoting balanced strength, and this is a partial inversion where there is some body weight that my shoulders are stabilizing, letting my shoulders just ride upwards is going to create a less stable situation, and I won't be operating from a place of maximum strength as my scapula are not secure on the rib cage as much as they could. The way I think about it is, so, this is a partial inversion. I mean, if I was doing chaturanga or plank pose, dandasana, would I elevate my shoulders? No. It's not as strong. Would I, if I'm, that you could think of down dog also as a way of, you could progress from down dog into handstand. If I'm doing handstand with full body weight being supported by my shoulders and my scapular stabilizers, would I elevate my scapula? No, it's not as strong. I wouldn't do that. It's like the same thing as if you lifted weights and you do an incline bench press. At the end of your bench press, incline press, are you going to then push your shoulders into more elevation? No. Just in terms of the functional anatomy and the goal of building strength and stability in joints, I don't understand why you would want to elevate your scapula in downward facing dog. If you have a different opinion regarding that, I would really love to hear your opinion and why you have that opinion. So please comment and I will reply. So to recap, what I think are common mistakes in downward facing dog with the shoulder alignment is people tend to just dump into hyperflexion of the shoulders, hyperextension of the elbows, and sometimes the shoulders and the arms are internally rotating and collapsing inwards, and then the elbows are bent. Also, the spine is in extension, too much extension instead of a more neutral position. And then people tend to elevate the shoulders instead of depressing them. So some of the cues, to recap the cues that you can use, is I tell students to widen their shoulders and let them sink down their back and don't push the floor away. Pushing the floor away encourages elevation of the scapula. I prefer to think of it as sinking into the floor and letting the scapula relax down the back. Then there's also that isometric external rotation to activate the serratus anterior and the mid and low trapezius to hug the scapula to the ribs. So to cue that, I say, as you press your hands gently into the mat, then subtly turn the insides of your elbows upwards towards the ceiling and feel your shoulder blades hug against your ribs and your shoulders widen. Another cue, not related to the shoulders, but the neutral spine, is to engage your core and lift your navel towards your spine. Now I'd like to talk a bit about pain, neuroscience, and yoga, and how this relates to the shoulder joint. So basically, in our society, we have a total misunderstanding of what pain is, how it works, and this is also in our medical community as well. So the common assumption is that if you have pain somewhere, there must be a local problem in the tissues, local injury. And this just isn't true most of the time. So here's a picture with some common types of shoulder pain that a person that has pain in their shoulder might get diagnosed with. Shoulder bursitis. So this basically means, and itis means inflammation. A bursa is a sac around the joint. So basically you have inflammation in that bursa. This diagnosis is meaningless. No one ever checks to see if your bursa is inflamed. And if your bursa is inflamed, what is the actual reason why your bursa is inflamed, and what can you do about it? That there's no information there. Shoulder arthritis, same thing. So arthritis is bone inflammation. So you have inflammation in a bone. Okay, why? Don't know. It doesn't explain anything. It's not a real diagnosis. Rotator cuff tendonitis. Again, tendon inflammation. So why do you have, why? Why is there inflammation in your tendon? Doesn't give you any information. It doesn't, there's no course forward with that information. Or bicep tendonitis. And these diagnoses are just assuming that there is a problem in the local structures there, and no one is ever actually confirming that with anything. You know, our whole understanding of pain, basically, you know, Descartes it came up with the model that, you know, in the 1600s that we still most people adhere to today, that we have sensors, pain sensors in our places in our body, and they sense pain, and then we get this pain signal goes to the brain and then lets us know that there's pain. But that is actually not how it works at all. We don't have pain sensors. We have nociceptors. Nociceptors sense danger. So they sense possible problems, and then you get a bunch of these signals going up to the spinal cord, and the decision to produce pain is made in the brain. And it's based on many inputs from the limbic system, many inputs from the peripheral nociceptors, and basically it's a summation of all these inputs, and then the brain decides to give you a like, you know, knock on the door, say, hey, there's a problem here, you got to check it out. I'm going to give you some pain so that you know, do something about it. Protective instinct. You know, but there's plenty of times where examples of when someone has extreme tissue damage and doesn't feel any pain. Say like a soldier on a battlefield, gets his arm blown off and has no pain, doesn't feel it at all, because the body decides that it's a survival instinct to not feel pain at that time, and so he can continue to get out of there or try to protect himself. And there's also examples of phantom limb pain, where people have pain and they don't even have a limb. Or people can have no obvious gross tissue damage and have a tremendous amount of pain. Like people that are diagnosed with fibromyalgia and things like that. So basically, the experience of pain is an output of the central nervous system, not an input. And this whole idea that there has to be soft tissue damage or some type of tissue damage, this whole idea of there needing to be an injury for there to be pain is wrong. And here's some quotes from Lorimer Moseley. He's a pain scientist, pain researcher, neuroscientist in Australia. He wrote a book called Explain Pain. And here's some good quotes from him about it. Pain is a synthesized impression generated in the brain based upon danger, nociceptive inputs. All are processed in the limbic brain. Emotional, historical, stress all contribute. Soft tissue damage is neither necessary nor sufficient for the experience of pain. And also, pain is an output of the central nervous system, not an input. The reality is that most pain is referred pain. There's no actual problem in the joint or in the local tissues, but pain is referred by trigger points in muscles, and the pain so you have a problem in a muscle, a metabolic stagnation in the muscle, in a part of it, and you feel that issue, you feel the problem though, in removed from where the actual problem is. So this is called referred pain. So here's a couple diagrams of this. And this was well documented by Drs. Travell and Simons. Here we have the infraspinatus muscle, which is a rotator cuff muscle, and it lives on the back of the shoulder blade right here. And where these X's are, that shows where there tends to be problems in this muscle when there's stagnation, and then or what we would call a trigger point, and I'll explain those in more detail in a minute. So you have a problem in the muscle here, but you don't feel it here. You feel it in the front of the shoulder going down the bicep. So this is the most common cause of anterior shoulder pain, is trigger points in the infraspinatus muscle. And as a coach in the body practitioner and trigger point therapist, this has been my clinical experience. I've treated many people in many different types of situations with a severe shoulder pain, and most of the time the issue was trigger points in the rotator cuff muscles and scapular stabilizers. Well, here's another example. You have a trigger point in the muscle, the subscapularis muscle that lives on the front of the scapula, the anterior surface of the scapula. But you don't feel a problem there. You feel it in the back of the shoulder. That's where it refers its pain. And also sometimes to the wrist. It's known to produce a band of pain around the wrist. People, relating this to down dog, people who do down dog that have wrist pain when they do down dog, often the direct referral is from this subscapularis muscle, because the wrist isn't even going into a lot of extension. You're less than 90 degrees of extension, so your wrist extensors aren't going into a big stretch or anything. And people have pain wrapping around their wrist. Well, the subscapularis is probably the direct referral of that, and the direct referral cause. So here are the pain referral patterns of a couple of the most important scapular stabilizer muscles. The one on the left here, this is your trapezius. So it's a very broad muscle with a lot of different fiber directions, going this way, and then going up this way. Upper trap, mid trap, low trap. So if you have an issue in your low trapezius here, you don't feel it there. You feel it as top of the shoulder pain, posterior neck pain, suboccipital region, very common, and right here into the top of the shoulder very prominently, close to the acromion process. Very, very common. Here is the serratus anterior muscle. So this is your primary abductor or protractor of the scapula. And if you have an issue in this muscle, you feel it. You might feel it in that muscle. That's possible, but more likely than that is you actually feel it going down the ulnar side of the arm, sometimes to the last two fingers. You can also feel it in that low trapezius area. So what are trigger points? Well, trigger points are basically a micro metabolic stagnation in part of a muscle. So here's kind of an example here. Here's our high trapezius muscle. Here's a picture of a taut muscle fiber, and here we're getting a very close-up glimpse of it. So you have muscle fibers, and then the individual contractile units of a muscle fiber are called sarcomeres. So what happens is you get a metabolic stagnation in some of these fibers, and this would be a normal looking muscle fibers. Here would be a contracture fiber or a trigger point fiber, where what's happening is you get the sarcomeres are super bunched up, very close together, and create a hard little tiny nodule, and then the sarcomeres going away from that nodule are super stretched and at length going out towards the attachment. And then the whole muscle fiber is very taut, and it is stuck in that state. So muscle fibers, in order to do work when the motor nerve says contract and do some work here, move this joint, they need a round of energy of ATP in order to contract and contribute to moving that joint. They also need another round of ATP in order to reset and go back and get ready to contract again. So what you have then in these muscles fibers that aren't doing that, aren't healthy, is a metabolic stagnation where there's no energy coming in, there's no waste materials getting removed, and so then you have the muscle fibers just stuck in this state. And you get enough of these in a muscle and you will start experiencing referral pain, because your nociceptive nerves are going to start registering that there's a problem here in this muscle. Your brain will decide to produce a pain, but you won't feel it in that exact area. You'll feel it in its referral pattern. So the way that pain referral works is that you get nociceptive signals coming into the spinal cord, and then we have what's called upregulation, where you get more and more of these signals are being produced and coming in over time, and then you get these interneural connections at the spinal cord that upregulate that pain response, and you hit a threshold where then all of a sudden this issue has to be brought to your attention, and the central nervous system decides you need to know about it and produces a pain response. But by the time it produces that pain response, you might be the interneural connections have moved up a spinal segment or two, and so you will feel the referral pain in a different area. So you don't feel it where you have the actual issue, where a lot of the original nociceptive inputs are coming in to the spinal cord, but you'll feel it in like a joint away. Just as an example, here is a common muscle that causes medial knee pain. So here's where someone commonly will feel pain, medial knee area, and there's no actual problem in the knee, but there are trigger point fibers, contracture fibers in the vastus medialis, and commonly in these areas here. So there's nothing to treat here. You need to treat where the problem is in the muscles. So knowing this information, you can go to, if you're feeling a pain somewhere, you can look at the pain referral charts and see what are the possible muscular contributors to this. It could be completely muscular, and often it is. So it is too bad. It's a real shame that our medical practitioners don't understand trigger points. Why isn't part of their education? I don't know, but they have to go outside of their formal education to learn about trigger points. It's not standard part of orthopedic medicine. But when they are trained in trigger points and recognizing them and doing trigger point therapy, the results are tremendous. So here is a study that was done in pain clinics with almost 1,000 patients. And these clinics were set up, these pain clinics were set up, and the doctors were trained to recognize and treat trigger points. And what they found then was that people coming to the clinics, myofascial pain syndrome was the most common diagnosis, 82%. Treatment included dry needling or trigger point injection, 82%, manual myofascial release, 23%, pharmacotherapy, 38%. Significant short-term improvement after treatment was reported by 75% of patients, and 72% reported long-term improvement. So those are astounding statistics, because most doctors don't recognize trigger points, know anything about trigger point physiology. So people coming to a pain clinic are going to get they're going to get pain pills. They're going to get physical therapy that is usually not effective because they're not trained in trigger points. Most pain is actually from trigger points, and you don't understand trigger points, then you're not going to treat the patient effectively. So this study shows that when doctors are trained in trigger point therapy, that the majority of people coming to them with pain get diagnosed with myofascial pain syndrome and get significant improvement. 82% was the people were diagnosed with myofascial pain issues. I mean, that's astounding. And then 75% had reported significant short-term improvement after one visit, and 72% reported long-term improvement, and that's just one treatment. The last part of this paragraph says the vast majority of patients referred to the clinics were treated using simple, inexpensive modalities while sparing referrals to unnecessary consultation visits, imaging tests, and medications. I have seen this stuff work myself. As a coaching the body practitioner, I deal with retraining pain-free movement using trigger point therapy. Coaching the body is basically an advanced form of trigger point therapy with a lot of innovations, and I've treated hundreds of people for shoulder pain conditions successfully. Here's an anatomical model showing the scapular stabilizer muscles. Here's the rhomboids, rhomboid major and minor. So they're running in this oblique direction, attaching the spine to the medial border of the scapula. So they adduct the scapula as well as elevate it. And then we have the levator scapula attaches the some of the cervical vertebrae to the top of the scapula, this superior angle of the scapula. So this can elevate the scapula as well as downwardly rotate it. And then these are the deeper muscles. And then more superficially, then we have the trapezius muscle. So we have the high trap here, that's an elevator of the scapula, and also bilaterally it's an extensor of the neck. And then we have these horizontal fibers here that are called the middle trapezius, that's a straight adductor of the scapula. And then we have our low trapezius, these oblique fibers this way, that adduct the scapula as well as depress the scapula. So on the other side of the joint, then we have the serratus anterior, and that is the strong protractor of the scapula and is also an upward rotator. Here's another diagram. We couldn't see the serratus anterior very easily from the other view, so I'll briefly show this. So here's some of the superficial muscles. Here's deltoid, hide, deltoid, hide. Then we have lat, hide, and infraspinatus. So here's our scapula. Here's some of our rotator cuff muscles. Here's our trapezius. Deep to that, rhomboids. There's the levator scapula. And then on the other side of the joint, here's our serratus anterior. Here's our pecs. I'm going to hide the pecs. Pec minor, I'm going to hide that one. That's another scapular muscle. The serratus anterior is a very big, broad muscle, and it's your primary protractor of the scapula, directly opposed to the rhomboids and the mid and low trapezius. And this is a primary muscle along with your mid and low trapezius that are working during downward facing dog to stabilize that scapula. The serratus anterior, so it connects on the front of the scapula along the medial border. So it goes underneath the scapula along the medial border here, and then it wraps around all the way to the rib cage. So when these muscles contract, then the scapula will protract or abduct, come forward along the ribs. Also, when these lower fibers contract, you're basically going to get the upward rotation of the scapula. So here's a diagram of scapulohumeral rhythm. So this is very important. You can check this out on yourself and on your students. It's very important because this is the source of a lot of shoulder dysfunction, although it's not recognized as such. The scapulohumeral rhythm describes, as the arm goes into abduction, how much rotation the scapula needs to have in order for that arm to abduct fully and to go through full range of motion. So what we have in this diagram is, here's where the arm is neutral, and then as it moves away from the scapula, as it abducts out away from the body, the first 30 degrees or so is all at the glenohumeral joint right here. It's all arm movement. Right? Then after that, for every 2 degrees of arm abduction, we need a degree of scapular rotation, all the way up till the arm gets to 180 degrees. So often what that is not happening on people. So their scapula are not rotating properly. If the scapula don't rotate enough, basically what happens then is you won't have full arm abduction or flexion, because as the arm abducts, you will hit the acromion process, which is part of the scapula, and so the humerus will bump right up against this because it can't rotate out of the way. And so that's where you get your rotator cuff impingement. And there's the supraspinatus tendon runs right through here, and your humerus, head of the humerus, is going to keep bumping and jamming that space and crushing that supraspinatus tendon up against the acromion process, and that's where people get the impingement, and that's where people get tears and fraying in that supraspinatus tendon. And so that, they might actually have a mechanical issue, a local injury in those tissues. But the problem, that's a symptom. The problem is actually that the scapula isn't rotating properly. So the scapular stabilizers are not coordinated together in rotating that scapula properly. Here's an example of the scapulohumeral rhythm and how to analyze it. And you can do this for yourself looking, using a mirror so you can see your back. And basically, you watch the inferior angle of the scapula and how that moves compared to the arm as the arm goes into abduction. So the inferior angles are the lowest point of the scapula. So right here. So you can, you can watch how that moves on some people. Some people you can put your fingers right on that lowest part, the inferior angle, and track it as it moves. On me, it's pretty easy to see. So as I abduct my arms, the scapula should move, should keep rotating as I go into full abduction. Now I'm going to come down, and I'm going to come out of it and see how my scapula are rotating the entire time. I'm going to do that again. So the first 30 degrees or so, we go back, the first 30 degrees, it's all at the arm. So I'll get there, so I don't see any scapular movement until I start to get to about there. Now, as I continue to abduct, you see the scapulas start rotating upward rotation. And then they continue to rotate all through that entire motion, all the way up to the top and all the way back down again. nice and smoothly. People that have shoulder issues, usually shoulder pain and shoulder weakness, they don't have this scapular rotation happening. You might see the scapula barely move until they get to 90 degrees, and then it'll start to move a little bit and then stop. And then they might only be able to get to here. Because that scapula if it's not rotating, then the acromion process right here, which is part of the scapula, is not going to move out of the way, and the humerus is going to bump into it, like I said before, and that's where you get that rotator cuff impingement. So watch how people's scapula move. And in a yoga class, this is fairly easy because you have them doing this type of motion a lot. And if someone's scapula aren't rotating properly, they don't have full arm abduction, you will see it. Here's an example of someone just raising their arms up overhead, very common move in yoga. And you'll see this on a lot of people where they can't keep their arms straight and touch their hands together. So this guy doesn't have full abduction capability of his arm. And that's usually because the scapula are not rotating enough. They're not rotating, and then you get impingement here, and you get the high trapezius gets very hard and shortened. We call that contraction on the short. So trigger points in your scapular stabilizers can limit your ability to achieve full flexion and full abduction of the arms, and that is very, very common in people that don't have full range of motion. The other thing that happens is, as I showed in those previous pain referral charts, is that the scapular stabilizers, the serratus anterior and the trapezius, are capable of referring pain to all different places of the shoulder. Top of the shoulder, front of the shoulder, back of the shoulder. So here is how the referral works. So previously I showed the infraspinatus muscle, that is the primary direct cause of anterior shoulder pain, and then the subscapularis muscle, which is the primary source of posterior back of the shoulder pain. And the thing is that these muscles, they might be the direct referrals, but they're set up by the scapular stabilizers. These are usually the primary source of any type of shoulder pain and dysfunction. The low trapezius can refer across the top of the shoulder. The serratus anterior muscle will refer pain up along the lateral border of the scapula into the infraspinatus and the subscapularis, which then refer their pain to the back of the shoulder, to the front of the shoulder. So that's what we call satellite referral. When there's a chaining effect from one muscle's referral, it goes over another muscle, then that muscle sends its referral pattern. And so you might only feel the end of the chain. You don't feel any of the other things. You feel posterior shoulder pain. You feel anterior shoulder pain. It could be directly from the rotator cuff muscles, but it's often the source is one more place removed down the chain of referral. So you have your serratus anterior and your low trapezius muscle that can cause all of those shoulder pains: top of the shoulder, front of the shoulder, back of the shoulder, and it's very confusing because it feels like it's in that joint. It feels like it's deep in this joint, but most often it's referred pain from these scapular stabilizers. With down dog, you are really, that's what you're doing, is you're really pushing the scapular stabilization. So those muscles can get into trouble from doing down dog, either incorrectly, that in a way that puts more stress on the stabilizing muscles, or if you do it, too gung-ho, too much too soon, you can overload those muscles, and that will create trigger points, and that will produce pain. So here's a couple ways that you can mitigate that. You can mitigate that with counter poses. So after you've done down dog, you can target the scapular stabilizer muscles with these specific stretches. So we have eagle pose. So and I'm mostly concerned about the arms in this pose. So basically you have the shoulders are going into protraction or abduction. And that's going to put a nice stretch into your mid and low trapezius and your rhomboids. And your serratus anterior on the front is going to shorten. So it's good to take those muscles through range of motion after you do a down dog. So here's a picture of a couple different variations with the arms. So here's the more traditional way, which requires a lot of protraction of the scapula. And here's a modification of just where you don't touch the hands together, but where you're still getting the shoulder into protraction. And here's another counter pose then, after doing the eagle pose. This pose actually, this is prasarita padottanasana C. And again, I'm mostly concerned with the shoulders in this posture. What's happening here is that the scapula then are adducting. Scapula are adducting, they're elevating, and they're downwardly rotating. So that's going to be a big stretch for your serratus anterior muscle, especially the low fibers of it that are responsible for producing upward rotation, which is what often blocks full arm abduction. So this is a great little combination after down dog to do, is to do the eagle pose and then do prasarita padottanasana C. And again, you don't even need to do the leg part necessarily. We're mostly concerned with the shoulders here. So sometimes, if you don't want to deal with the leg abduction, you can just do it with legs together and just fold forward and let your arms come over, and that will give you a great serratus anterior stretch. So I will demonstrate those. Here's the eagle pose. So you can see the scapula are abducting or protracting, going away from the spine. So getting a good stretch on the rhomboids and the mid trapezius. Then I'll do the other side. Again, from behind you can really see how wide this is here, how the shoulders, the scapula are abducting, protracting, moving away from the spine, really stretching the mid-trap and rhomboids. And then here is prasarita padottanasana C. And here we're really getting a lot of scapular adduction and elevation, which is going to really stretch serratus anterior, especially those low fibers of serratus anterior. So that feels great. And that's a nice way to keep those fibers, those muscles healthy after putting them under load and putting them to work in the downward facing dog. So a great way to maximize the effectiveness of those counter poses for downward facing dog is to use post-isometric relaxation, also known as contract relax stretching, in those postures. So basically what we want to do is we want to do a contract relax stretch for those muscle fibers that we are just putting under a lot of load and getting and asking a lot of performance from: serratus anterior, low trap, mid trap, rhomboids, those muscles. We can do contract relax stretches, and that will facilitate the release of any trigger points that have developed. So this is a way to treat the scapular stabilizers for trigger points, is using post-isometric relaxation, contract relax stretching. You can do this in any yoga pose. So in this example, we're doing it for the scapular stabilizer muscles. So just a little bit about how this works, and then I'll demonstrate it. Basically, in your tendons, you have Golgi tendon organs. So the tendons attach the muscle to the bone, and then in these tendons you have Golgi tendon organs, and what these do is they are like strain gauges. So they detect how much tension is being put on the tendon by the muscle, and then it sends a signal through the spinal cord, and then there's a reflex arc back that causes a relaxation response in the muscle. This is part of the control system. So we have smooth, controlled movement. So the same muscle that's getting a lot of tension put into it by contraction is also at the same time getting a relaxed response from the spinal cord. So that's how we have smooth, controlled movement. So post-isometric relaxation is basically a hack of this neuromuscular system. So we can use this Golgi tendon response and hack the nervous system and treat trigger points and get more stretch out of these contracture trigger point fibers. That's how we can normalize these fibers and get their metabolism flowing again. The way that you do that is you take your target muscle. Here's an example with the hamstrings. So you take your hamstrings, and so you take them off of their stretch, a good amount. I would take off at least 20% of stretch, and then you engage the muscle. So step one, we're going to take the muscle off of stretch, and we're going to engage it. So in this example, we engage the hamstrings. And it doesn't have to be a big contraction. You can just do a little contraction, just enough to engage the muscle, 10 or 20% of maximum. So we do a submaximal contraction of the target muscle, and then we do that as we take an inhale, and then we hold with that contraction. You hold that for 5 to 10 seconds, and then after that, you exhale and then relax that muscle, and then take it into stretch. So here, now the hamstring is being taken into a stretch position. And you can usually get 20 to 30% more stretch than you normally could by using this PIR neuromuscular hack. And you can even repeat this process a couple times. So let's see that in action. Here it is with eagle pose. So I'm contracting my rhomboids and my mid-traps here to adduct my scapula towards the spine. So I'm going to do that. So I'm engaged and I'm holding with my inhale. And then I'm exhaling, and now I'm going to take those muscles into stretch with those eagle arms. And now I'm abducting the scapula and stretching those fibers that I had just contracted and shortened. I'm going to do it again and wrap my arms the other way so I get a big stretch for each one. So this time my left arm was going underneath. The first time my right arm was going underneath the other arm. So that's how you do a contract, relax, stretch for in eagle pose. And now let's see it in the prasarita padottanasana. So here I'm actively upwardly rotating and protracting my shoulders. So that's shortening and engaging my serratus anterior. So serratus anterior is contracting. And so this is my contraction. I'm with my palms together. Serratus anterior is contracting. And I'm doing that with my inhale and holding it. And then with the exhale, I come into the stretch position and I let my shoulders elevate and adduct. And that's a great stretch for the low fibers of that serratus anterior. That's another thing too, is so after I go down to my maximum stretch, then another thing I can do is I can do another round of it. I come off the stretch barrier and now I'm engaging. So basically my stretch was down here. My arms were down here, and then I came off of my barrier, brought my arms up here and held them there. So that's engaging my serratus anterior in that upward rotation. And I'm going to hold that for 5 to 10 seconds with my inhale and then come back into the stretch again. So that's another round of contract, relax. That's contraction. And then I'm relaxing with my exhale and letting my arms come down towards the floor again, going back into that stretch. Thanks for watching. I hope this video helped you out. I hope it helped you understand the anatomy and the alignment of shoulders in downward facing dog, and also that most pain that people feel, especially in shoulder pain related to down dog, is not injury per se, but is actually referred pain from trigger points, and that the scapular stabilizers are the most common cause of pain, shoulder pain in downward facing dog. And I hope I gave you a couple ideas of how to treat them, how to coach treatment in them with contract, relax, stretching in eagle pose and prasarita padottanasana C. And if you want a more in-depth explanation of shoulder pain and how to self-treat it or coach someone in self-treating it, we have a wonderful webinar training on that at Coaching the Body Institute, and that is linked in the description as well as right here at the end of this video. I'd love to hear from you with any comments about this video, any questions, and also if you have any suggestions, any other areas or postures that you'd like me to make a video about, please let me know in the comments, and I'm taking requests. Thanks.